Hi, and welcome to the HQ podcast. For those tuning in for the first time, the HQ is a podcast serial produced by CHA Learning and is your trusted source for conversations on healthcare issues and topics from the perspective of those that are leading and impacting the health system. Together, we'll explore these topics as we continue to learn together. CHA Learning is a professional development division of Healthcare Can and is uniquely Canada's only national fully online learning provider serving all of healthcare. So please check out more about our learning programs and services after this episode and discover how we collaborate with health leaders and organizations like those we feature on the HQ to empower healthcare professionals with the knowledge, skills, and relationships to impact health system improvement. Hi, I'm Dale Sherbeck, and thank you for joining me today for another amazing conversation. As we collectively and regionally continue to search for solutions and strategies to manage and build better from our long-ranging health human resource challenges, several concepts have continued to be focal points in our discourse. Outside of the health and wellness and retention of our current workforce, much of our discussion has focused on supply and demand and potential solutions like looking to internationally educated health professionals or by increasing our domestic supply through revamped education models. But overlaying or cutting across many of these ideas is another that goes to the heart of a couple of wicked questions. Are these the right roles for our current and future health delivery system? And are those that are staffed in them doing the right work that best leverages their knowledge and skills? What I'm describing is the question about models of care and scope of practice. You have likely heard these phrases yourself, but what do we really mean by them? And beyond theoretical blueprints, what does this look like in practical terms? How can this address and impact our current needs? And what are the challenges associated with these concepts? And if we choose to go there, how do we get there? One of the challenges with discussing these topics from a purely HR perspective is that it isn't just an HR issue or solution. It clearly impacts clinical services and patient care. And many HR leaders who dare to go there will be met with resistance and objections that could include, you're not a clinician, you don't understand what we do, your job is to staff positions, not redesign care. Today's guest, however, sits in a very unique position in one of Canada's largest academic health science centres, the Ottawa Hospital, or TOH as it's known to many. Suzanne Madore has spent 33 years in nursing, beginning as a frontline nurse and continually moving up to become the Chief Nursing Executive and now Executive Vice President, Chief Operating Officer for the Ottawa Hospital. Even with all her many successes, she maintains her humility and has never lost her bedside manner, respect for the profession, or empathy for staff on the front lines. And as I can attest from many conversations with Suzanne, if anything, she is more in touch as she continues to solve some of healthcare's biggest problems, like surgical wait times, staff burnout, hospital occupancy, and new models of care. She explores all avenues, including public, private, and cross-hospital partnerships, and is willing to take risks to make improvements for staff and patients. So hi, Suzanne. Welcome to the HQ, and thank you for joining us for a further breakdown of this topic as you share your own work on these wicked problems.
Thank you very much, Dale, for considering me. It's a true pleasure to be here. This is what I do and this is what I love. So always exciting to talk about those things.
Yeah, and I love conversations with you. I always learn so much through it. So perhaps we can start the conversation with your own story, Suzanne. It's a very unique story in terms of your rise and your professional sort of evolution. How does a person go from being a frontline bedside nurse, as you described 33 years ago, to a very unique set of roles and positions you hold today?
Sure. So what I will tell you is a long, long time ago, I decided that I wanted to be a nurse. And what drew me to nursing was the caring aspect, the compassion aspect. I also had a large volume of nurses that I was exposed to in my family. And I'll tell you, my grandmother always wanted a nurse in the family, and I came from a very large family in the Ottawa Valley. And so making sure that my grandmother's wish came true was certainly one of those things that I wanted to make sure I achieved. I was always interested in health sciences and the medical field, and just watching nurses, whether I was exposed, in the environment or whether it was something that I watched on TV, it always drew me
Hmm.
drew me in. And so fast forward to, going away to school, coming into TOH. And in fact, I've been here 34 years. I will be entering my 35th year here at TOH. But being exposed to all that there was to offer in terms of opportunities in nursing, like no other profession that I'm aware of has so many opportunities to grow, try different things, be exposed. Whether you're in the education pathway, whether you're in leadership, whether you're a frontline nurse, getting to do things like neurosurgery, thoracic surgery, oncology. I mean, just the world truly is your oyster. And then seeing some of the great leaders, obviously some of the not so great leaders as well that I've seen in the past, always wanting to inspire, motivate others, no matter who I was working with. Saw the opportunity to get to build my own team, form that vision, if you will, as a team, how we would deliver care, and that common goal for doing better by patients. I think making that positive difference for people was really what drove me to then my first leadership role. And to be honest, to be where I am today was more than I ever knew I wanted. Looking at driving improvements in the system, looking at driving improvements that made the profession stand out for nursing. I love working with people, focusing on being solution oriented, looking at the lives of our patient, and being a human-centered leader is really where I find pleasure in my everyday. We're very fortunate to have the opportunity that we have as nurses and as leaders, and I never want to take that for granted. In terms of where I am today and the COO role, obviously looking at the big picture, the health system, if it were, and how can I make a difference? How can I work with my team, listen to the team, listen to the people who are working day in and day out, and be able to make that real difference for them, and hope that I leave, my time in this field with that lasting impression.
Very interesting, Suzanne. Thank you. So, sort of layering on top of that, I guess, your own personal context, maybe provide a bit more context for what's happening at the Ottawa Hospital. For those that maybe not be as familiar with your workforce and some of the challenges and the landscape of nursing today within your institution. And maybe situate within that, like we bandy about this term around an HHR crisis. So, what is that current state that and challenges that you're facing there?
Sure. So TOH, it's a large academic organization, one of the largest in Ontario and in fact in Canada. We do service a very broad area in terms of Eastern Ontario, as well as many patients close to the border. We're close to the border, and so service some of those patients. None of it have special agreements. So our catchment's even larger than it looks if you were to look at a map. But we have approximately 4,500 nurses. The reason I say approximately is because, of course, on a day-to-day with that large a number, you can see numbers go up and down a little bit. But this includes roles such as registered nurses, registered practical nurses, nurse practitioners, clinical nurse specialists, advanced practice nurses, nurse practitioners, clinical managers, clinical directors, executive directors, who are all nurses.
Wow.
Approximately 60% of our nursing workforce is in full-time positions. And in terms of generations, to give you a flavor, so today we see about 66% are millennials, between millennials and Generation Z, and then 7% are boomers. And so what you see from the millennial and Gen Z, they're very technically savvy or astute. They're adapting easily to things like our electronic health record, Epic, and some of the other technology that we're seeing in our environment today. And but then, with 7% of boomers, you see that critical thinking, the mentorship, and the wealth of experience starting to decline, if it were. So 50% approximately of our nurses have less than 4 years experience within our organization.
Wow.
Yes, so certainly gives you a different flavor of the experience within the organization. And about 9% currently are on LOA, the majority of those being maternity leave. But when you think about even that age range, right,
Hmm.
and the percent millennial and Gen Z, and think about childbearing years and 18 months for maternity leave, you can almost start to plan your workforce and your future, right?
Hmm.
And that really is where we're at today, understanding what we have today in the organization, but as well getting ahead of it and planning for the future, which is what we've not done well in the past, I would say. So when we looked out over 5 years and even looked at those eligible for retirement between Gen X and the boomers, we had like 500 possibly eligible for retirement over a 5 year period. That's a lot.
Yeah.
That's a lot of nurses. So how do you plan for that and get ahead of that? We know that nursing vacancies in Canada have more than tripled in the past 5 years, and we are no different, right? We have seen vacancy rates as high as 30%. Sometimes a wee bit higher in some of those feeder units, particularly the emergency departments, critical care units, or the operating rooms, where we've been asked to do more. Because we know that we've built this, what we call a backlog in surgical cases, given the shutdowns over the course of the pandemic. Now, we've also done a great job at recruiting, I have to say, being the large academic organization. Number one, we had great success with a communication campaign that we launched last year. But in addition to that, given the academic mandate and nature of the services that we provide, often we are attractive
Hmm.
to nurses who are interested in looking at diversity in terms of their career. Now, turnover, I'll just say turnover is a very difficult metric because we've added close to 200 beds over the past 2 to 3 years in the organization. And so you would expect turnover as you add beds and new positions. That's opportunity. I see turnover and opportunity one in the same,
Yep.
depending in what you're looking at. But for nursing, that's certainly the case because there's opportunities. But really, when you're thinking then about the future, we're building a new campus. And so there are going to be that many more beds to fill. We know how long it takes to recruit nurses, and most certainly at the same time retain the ones that you have, but you need technical expertise, things like we haven't had to look for in the past. These are the types of skill sets that now we're going to start to look for, because as you build this facility with all the technological bells and whistles available, you need to make sure that you're giving that lead time to be able to prepare your staff. I think the other, a blessing and a curse at the same time is that tripartite mandate, which is the academia, the clinical, and the research. Because
Hmm.
while during the pandemic, what we saw was clinical took up 100% of the time. So the focus on academia and research, had to take a back seat while everybody was working to just provide care for patients. And so now trying to inspire and motivate nurses to do research and understand that the evidence comes from the research that they're doing, and how it connects essentially to the care that they're providing, as well as the academic efforts and pursuing that higher education, being able to have that flexible workplace, all the while still going back to school and doing things that we've all done over the years, but it truly does look different in today's work environment. I think the other big area of focus is around obviously wellness and burnout. So, when you don't have enough people, you don't have enough relief for vacation.
Hmm.
Your vacation quotas are minimized so that you're making sure some people get vacation, but you also don't want the burden of additional workload on the staff who are still working in the environment. So things like shift work, some of the other things that nursing brings does not promote that wellness and burnout. So understanding how you do flexible work schedules and still provide care 24/7 and try to help support wellness and burnout. But then there's the practical reality of looking after the patients who need the care 24/7.
Wow. So there's a
I know
lot.
that's a lot.
Yeah,
Yeah.
well, there's a lot going on. I mean, you have a lot of competing priorities, a lot of stressors on your workforce in terms of filling for the pandemic. You're in a trajectory for growth. You're changing your case mix to some degree. You're dealing with backlogs. You're dealing with the potential for so many retirements uh, and I guess what you sort of insinuate, but right, I mean, is that you have a largely a female workforce, I guess, right,
Yes.
that is young,
Yes.
and as such, um, they're in childbearing years if that's the choice that they're going to make, and so those added pressures in a younger workforce that's coming on top of everything. So that is a lot. So I mean, it does lead to, I guess, my next question, which is, outside of that, I mean, what are some of the hard truths you think that, you know, health leaders like yourself and others sort of need to consider as we tackle this HHR crisis? And, and I guess, part of what we've just talked about is a part of the impetus for change, but really, what is that burning platform that you're working from?
So I would say first and foremost, supply versus demand. I mean, it's far outweighed. I've heard from multiple provinces whom I have the pleasure to work with leaders from across Canada and have heard that their seats are not even getting filled in nursing schools today. And so where, schools used to have to be choosy if it were about who was applying. Now they can't even fill their seats. And so when you talk about all of the challenges that I just described in terms of being able to meet the necessity of our workplace and deliver care, how do you do that when supply is not even coming close to demand? So I'd say the other is the widening experience gap. So as patients become more complex, particularly as they don't have family doctors, potentially with services that were ramped down during COVID, they did not seek care, and so they're coming in. They're more acute and complex in terms of their presentation, but the staff are more junior, as you've heard from me, in terms of the amount of experience. Now, junior doesn't mean they're not fantastic care providers. It just means they need more time to develop the critical thinking, right?
Hmm.
And deliver the type of care that may be required with the complexity in our patients. So, is there something you can do differently as that gap widens between complexity and experience? Are there different ways to expose nursing students while they're in school? Is there something more you can do upfront so that they come out better prepared? And certainly you see the preparation of the students graduating today or the new nurses graduating today in comparison to prior to pandemic, right? We had to do things like virtual learning, hybrid environments, and nursing really is something that needs hands-on, needs
Hmm.
that experiential exposure. And certainly you can see that there was less of that. I think we have to look at the right leadership. What are the leadership attributes that we need today in terms of connecting with people? You need people who are going to be brave but compassionate. You need people who are empathetic, who are going to listen and act. I think there's more competition than ever. And certainly, some roles are more attractive, whether it's they pay more, you have the opportunity to travel. I talked about sometimes scheduling in nursing.
Hmm.
We are a 24/7, 7 day a week. So if shift work is not your thing, there are opportunities on every corner. And so competing with a Monday to Friday daytime only um, job is tough if you're not attracted to that tripartite mandate that I referenced earlier. I think the other is in healthcare in particular, people are burnt out, they're tired, the workloads have been stressful. It's going to be really tough coming back from that and the impact that the pandemic had, being able to stay connected to your organization, connected to what brought you to nursing in the first place. I think we saw nurses who felt like they had no autonomy in terms of decision making, right? And then you look at the impact of things like Bill 124 on nurses and how it made them feel as professionals. And so how do you move past that? What can we do as leaders to help them with that? And I think retaining top talent, I mean, that's what attracts other talent, right?
Hmm.
We talk a lot about recruitment, but really you're nothing with recruitment if you're not also retaining at the same time. And so I think you have to look at those strategies together, and one does not mean putting the other aside. I think the integration we talked, or you mentioned internationally educated nurses. And so while we've made some strides in making it a little easier for our internationally educated nurses to come into the field and practice in our province, I think there's still a lot of work to do. We need to be able to give them the support. They're coming from a different culture potentially. And so integrating them into the workplace may take some adjustment. They need supports, they need some mentorship, and people who understand and who've been through some of the challenges that they're faced with. I think stress associated with acclimating into the new organization, but as well potentially the entire environment for them and their families, the costs associated with things like registration processes, and then the amount of time it takes to get things right, going through all those hoops. I think we really have to consider that and the stress on our internationally educated nurses. Um, but I mean, overall, the hard truths are sometimes, they feel insurmountable and that we don't have solutions for them, but I think we do. And I think we have to listen to the voices and we have to collaborate to be able to develop solutions together. That we won't do this if we're out on our own trying to develop
Hmm.
solutions that are not meaningful to the nurses and the people who are providing the care.
So speaking of, I guess, of solutions, and I think it leads into the main focus of our conversation here today on models of care. I mean, you've had a long career yourself in terms of you've seen different versions of I guess our current model. You're a student of nursing yourself in terms of understanding things that have come before, and you're an executive in a place sort of imagining new futures that sort of account for all these challenges that you've enumerated here. So maybe you could walk us through a little bit about, I mean, when we talk about a model of care, I mean, what is our current model of care, and what's come before, what are we talking about in terms of looking forward to like new, like a team-based model, as an example?
Sure. So definitely there's been different iterations over the years. It really has depended on supply and availability of best practices, what theory was predominant at that period of time, as well as what evidence was being published. The other really is sometimes the culture of the organization, because
Hmm.
you could have two different organizations at the same period of time looking at two different models. So what fits for one doesn't always fit for another. And really, the whole basis for nursing, right, started with Florence Nightingale in the 19th century. But regardless of the time period, nurses are always at the center of the care team. And then really what changes is what supports are available to them as that, captain of the ship or the coordinator, head
Hmm.
coordinator of the entire care for the patient. But some of the different models that have evolved over time include primary care, total care models, functional care, and then you mentioned the team-based model, which we see more and more of, because as that supply-demand gap grew, it really, it gave us the opportunity to take a step back and say, who is best to provide that particular part of the care trajectory? So, who has the skill set, the training, the education to best deliver on that? How do we collaborate and work together to ultimately deliver the care that the patient needs? And so sometimes it's aligned with a particular disease site or trajectory of a patient grouping. So,
Hmm.
and depending on the care that they need is the best makeup of that team. So, if I give you an example in orthopedics, one could imagine that the physiotherapist is a huge part of that care team in
Hmm.
delivering what the patient requires. But then, if you look at another type of care, so palliative care as an example, or oncology based care, you can imagine that, the potentially social worker or the registered nurse in delivering systemic therapy or chemotherapy may play a larger role in terms of the team-based model. But it really is the team members, healthcare professionals working together to deliver exactly what the patient needs to optimize their outcomes. And some models are delivered in a way that is more efficient than in other ways, but I think there are two things that I think have to be present. One is collaboration, so
Hmm.
the team working together, so not at crossroads, and understanding how each functions in order to make sure they're delivering the best possible care. And the other is communication, strong communication. So things like handovers and transitions and, from one provider to another. That's the difference between a primary care model where there's one person responsible for delivering the care and you deliver everything. You can
Hmm.
imagine that that's going to be less efficient, potentially less effective, because you may not have the best skill set, experience, and education to deliver every single piece of that care,
Hmm.
but it may in fact reduce some of that risk of transitions and handover because you're the only one delivering the care, if that makes sense.
Yeah, makes total sense. So yeah, if you're going to leverage more people with more skills that provide parts of the care, I guess, that a person needs, then yes, it's going to emphasize the need for better communication and other interpersonal sort of skills necessary to work in a team environment. Whereas if you're a one person show, you just have to get along with yourself, but then you've got to know everything. So.
Exactly. There, that's an excellent summary.
So as we collectively and you yourself sort of talk about new models of care, I mean, what are the implications that you're wrestling with? What is that going to do to change, I guess, care delivery? How's it going to change the role of nursing, and how does it to some degree answer this challenge that we're in terms of our crisis?
So I mean, team-based care to me is a necessity today, given that supply-demand gap or demand-supply gap that I talked about. Obviously, as resources become more scarce, we need to be more innovative in the way that we're envisioning how care can be delivered. And this is across disciplines. I mean, most of the professions that I've referenced are regulated health professions. So they have their own colleges, they have their own standards. So they are still working within their scope as met by, whether it's their college standards or through their education skill.
Hmm.
But it's fostering that collaboration, partnering with communities, looking at the patient along the trajectory. So not only is the team-based model within the walls of the organization, at TOH, but it's also about, the patient was somewhere before they came here and has to go somewhere after they leave here because they don't typically come into hospital for their entire lifetime and spend it here, right? And so, how do we work as well with others outside the walls of the organization to ensure that those care needs are met and they truly are part of the team as it is seen through the patient's lens. So understanding what's important to them. Um, and then I think, leveraging the role of all team members, um, focusing on communication, as well as that collaboration. So you need to build that before they get on the floor and start working together. And then you need to foster it after they're there. So, how do we again work with the schools to build an understanding of how everybody fits into this team-based model, and what is within the scope of the physiotherapist, the not feeling territorial, but more understanding how
Hmm.
we each work together to deliver the care and optimize the patient's outcomes, essentially. So there's no place in this for ego, right? This is really about putting the patient at the center and delivering what care they need.
Obviously, given your own professional background, you understand sort of the care aspect of this, the clinical part of the care model. Um, from the operations hat perspective, um, there's a lot of moving parts here as you manage these resources at some level, right? Which is not to dehumanize it, but it is putting people in different boxes in some respects. So I mean, what does that mean, and how does it impact these other roles that you've outlined in terms of a part of a team-based approach?
Yep. So I think some of it, happened because it had to happen,
Hmm.
essentially, right? Like the necessity was there. And so as you had vacancies, we tried to envision, what roles are out there available to us to provide the gaps that we've identified in terms of the total care required for the patient, and
Hmm.
try to match the skill sets with the care that was required. I think the other is change management, working with the teams, understanding what supports the teams who were in place. What support do you need? How can we best help you to deliver on the care that you expect to deliver, that we expect you to deliver, and that you were trained to deliver? And so some of that does require funding. And so looking strategically at where your investments are, advocating to ministry, we have seen some great support in terms of some of the financial supports available for roles like clinical scholar, the externs, which weren't just limited to nurses, right?
Hmm.
Many of the students in allied health disciplines as well were incorporated. And so we would like to see that funding continue. We created roles like clinical coach to provide a mentor. So these were retired nurses that came back to the workplace, didn't come in a traditional role where they were providing hands-on care. They, in fact, were side by side with a group of novice nurses to be able to provide mentorship, help embed some of that critical thinking and some of the learning um, in the clinical workplace. And so, looking at some of those roles and understanding where the gaps are and how you can build the team to essentially fill the gaps. I know that that sounds rather harsh and maybe
Hmm.
um, but it really is meant to understand how to support the nurses that are providing the care. Where can they not deliver best possible care, and how do we help them do that? What supports are available? What other roles are available? And how do you build a team then from that? And so, really optimizing what you have, all the while you're advocating for other funding to help.
So how, I mean, this is change, right? I mean, so how does your workforce respond to this? I mean, and how does it impact your culture as a whole? Even, I mean, as you continue on this path.
So, I would say, you know, early days still will be early days for a while. I think, any of us who've been in healthcare as long as we have, I worked 15 years frontline nurse and then went into leadership roles. And I have to say, I've never anticipated the impact, and what happened over COVID. Didn't think I'd see that in my lifetime, but I have, and so we need to take those opportunities. And how do we grow from this, learn from this, and do better? Essentially,
Mm-hmm.
many say you should have seen this coming, right? Whether it's nursing leadership within organizations, whether it's provincial, federal, and perhaps yes, we should have, but we need to move forward. And so, how do we do better and actually plan in terms of culture? I mean, some of this is revisiting, redesigning, understand the why, understanding the need, that burning platform that you talked about. But I think we have to make sure we're engaging with our staff, and not just engaging, but in fact we're listening. Goes back to those leadership attributes that we talked about that are necessary today. I think the other is developing a common vision and a strategy for nursing. We are about to embark on that journey. And so, again, will be imperative to have the frontline nursing voice. And I don't think before this we've been ready for that, to be honest. We needed to be in a place where you can take a step back and now start to think about a future and start to develop that vision, a vision that nurses can see themselves in and connect back to the organization, connect back to why they became nurses in the first place. And so culture has changed. No matter what anybody says, any organization culture has shifted. Now, culture helped us get through the pandemic and
Mm-hmm.
kept the people here and rooted and grounded the people who chose to stay. But I think we're changing that. We also changed CEOs um, just as the pandemic hit. So that in and of itself also changes, right? With a new CEO comes a change in leadership and governance. And so it's been a lot. We also implemented our electronic health record just
Mm-hmm.
prior to the pandemic, and we went big bang. So it's a lot of change in a short period of time, but I really think we're in a good place time today to now start thinking about the future and setting forth that path and working toward creating that vision.
Hmm. So I think, a key component, at least in my conversations with you in the past, has been the the combination of your I would say your two roles, but you have more than two roles in truth. Um, so how does that work in terms of you being the chief nursing executive, the COO who also has some oversight for HR and other parts of the organization? I mean, has that enabled sort of some of what you're talking about here? Does it create other kinds of challenges within the organization in terms of your fit? Maybe you could sort of describe that in a bit more detail.
Sure. So I have always been very practical and a realist. And so you can advocate for the profession of nursing, you can advocate for nurses, but still advocate first and foremost for the patients. After all, that's why we're all here, and advocate for the organization as a whole. And so, from my perspective, it doesn't have to be one or the other. And I think sometimes that's where we get caught. I think the other is, historically, we've seen working in silos. And so when you're imagining initiatives or solutions, you're imagining them within your own silo. Well,
Hmm.
I have a corporate lens. I have the best interests of the nurses. I have the best interests of the housekeepers in mind. I have the best interests of the patients in mind. And so I come from a different perspective. And when it comes to running the operation, you don't run the operation without the people.
Hmm.
And so if you're not considering all of the people and their best interests first and foremost, then you're also not a very good chief operating officer, I would say. And so I think they really do go hand in hand. Now, in terms of challenges, for sure, there are times when I know nurses would like to hear from me. It's all about nurses and only nurses. And
Hmm.
I'm a nurse first. I grew up wanting to be a nurse, as you've heard, and I've grown up being a nurse.
Mm-hmm.
And I consider myself a nursing leader. So whether I'm COO or chief nurse, my background is by profession, I'm a nurse. And I still believe very strongly in the profession. And so when I'm at a table, I'm advocating as a nurse, but as a chief operating officer. So, to me, they're one and the same. They're
Mm-hmm.
not two distinct entities. Where in past, I think by virtue of having different people running different pieces of the structure, that's where you land in silos. And the other is the output at the end, or the initiative and the solutions that are proposed, are coming from bottom up and top down in some cases, depending on
Mm-hmm.
what's happening and what the need is. But it's coming from a place and a perspective of nursing and operations.
Yeah, I think, in a more traditional role model, right? Everybody at the Ottawa Hospital or health organizations are working towards the common interest of patient care, right? But they're coming to it from different perspectives, and trying to balance those things. And I think so those things will create, conflict of visions, or different approaches that an organization through its leadership has to reconcile. But I think what you're describing is that you can find a way to balance those things more easily because they're both invested in you and you have that same common vision. Um, how does some of this then work within the, the other roles within an organization? So, are you describing, or maybe there's another question that I could ask first, which is, are you in changing these models? Are you going to envision fewer nurses ultimately in the end who are doing different work than they are today, maybe more meaningful work than they might have done in the past? Um, and and if that is the answer, or part of the answer, and you can correct me or refine that, how does that then be responded to by, let's say, your physicians, who are used to a different model of care or relationship with those clinicians?
Yeah, so certainly we have not seen a reduction in the number of nurses over this time. As I say, we continue to add beds, and look for other opportunities to fulfill nurses, to engage nurses in terms of delivering care that is at their level. And so, there's nothing more frustrating than any healthcare provider to be doing work that is seen not as meaningful to
Mm-hmm.
them, right? In terms of engaging them in the workplace. Um, so I would say we're not looking to decrease certainly nurses as part of the care teams. That's only been increasing, and we can expect to see more. In
Mm-hmm.
fact, as we look at the new campus, we're just putting numbers together now in terms of how much more workforce we need to build. And I know the numbers will knock us off our seats, I'm sure, at some point. And so expect that only to grow. But it will be more meaningful work. And in terms of, physicians and others, I think they develop very collegial, respectful, two-way, relationships when they're on the front line. Some of my best relationships over the years have been the team that I worked with on the floors. In fact, that long-lasting, right,
Uh-huh.
memorable relationships that were developed, and I think that will always continue. And I think the same for all of the allied health professionals. I think those relationships are key. You work so intimately, and in some of the hardest, most challenging situations, that you naturally develop those types of relationships and that respect. And so I don't see, physicians are the first to come to the table to say, oh my goodness, those nurses work so hard, or we need more of them, or I want a nurse practitioner. I see the value in the role of a nurse practitioner, an advanced practice nurse, in terms of my clinic or my area, whether it's my unit, etc. And so I think we've heard nothing but praise for the work that nurses and all of the allied health professionals do in terms of delivering the care. That's what everybody wants, is just to
Hmm.
deliver the care that they, set out to deliver and have expectations of themselves in terms of the ability to deliver. And so how do we empower them to do that?
Well said. Thank you. So, I mean, what's next on this journey as you continue to move down this path?
So we've actually just had an engagement survey, and so we are now compiling results, really doing a deep analysis in terms of understanding the level of engagement and where where we need to focus our efforts in terms of improving or engaging, increasing that engagement, as well as the nursing retention toolkit was just released
Hmm.
federally, and so doing a self-assessment against, the buckets that have been, produced for us essentially, from the ground up, and make sure we are meeting, what the evidence is showing
Yep.
we need to be, and then building a nursing strategy. So I talked about that a little bit, just about to implement that process and align it with, so we've developed a people strategy and an education strategy. As I said, we have a new CEO, so of course that's always the time to renew your strategies. And so making sure that all of these strategies align,
Hmm.
creating that common vision, understand everybody in the organization, understand the direction that we're moving in. Um, Obviously, continuing to foster the a workplace, healthy workplace of choice, embed wellness supports. We've done a ton over time, but we can't take our eye off that. That needs to be, an always every day efforts focused on that. Advocacy, obviously, at provincial and federal level, whether it's funding, for some of the supportive roles that I talked about, or, making the internationally educated nursing process, a little easier, looking at consistent, relevant data to support the workforce planning that is much needed. So we do get ahead of it, and we're not looking at ourselves in the mirror saying, "Hey, how did I miss that?" Right? We never want to find ourselves in a place like this again. And the other thing, that tripartite mandate with the education strategy, a research strategy, connecting people back again to the reason they came in to work, to this profession in the first place, and particularly why they chose TOH, looking at that value proposition, what keeps you here, doing stay interviews, changing our frame of mind, never mind exit interview. It's too late by the time they're exiting, right?
Hmm.
So what really is going to keep people here and driven and motivated to do the work that needs to be done?
Wow. So a lot, a lot more that lays ahead for you, but a lot of sage advice there. But so maybe just building on that, maybe as we come to a close, Suzanne, for other organizations that may be embarking on this journey, looking at their different models for their organization, what would be your advice to other leaders that sort of are contemplating this?
I think you have to have an open mind. I think you have to listen to your people. You have to understand what's happening on the ground. Get out there and talk to people. Understand where, the holes are and the gaps are, and really get ahead of it. Don't wait.
Thank you for so generously sharing your time and your experience, wisdom, and the work that you're doing at the Ottawa Hospital. It's been a wonderful conversation, Suzanne. So thank you again.
Thank you very much. It was my absolute pleasure.
Okay. Talk to you soon.
Bye.
You've been listening to the HQ, and I'm Dale Sherbeck, your host. You can find this and other future episodes on the CHA Learning website, Apple Podcast, or Spotify. We'd love to hear what you think, so please follow us on our other social media channels. Thanks for joining us in this discussion today. Please join us next time.